Hi, and welcome to the Reapparition Journal podcast. I'm Taruni, editor-in-chief of Reapparition Journal. At Reapparition, we're interested in not just how medicine works, but how its core concepts like life, death, and responsibility are defined and lived in practice. So today's episode features one of the most fundamental and yet deeply complex of those concepts, brain depth. I'm honored to be joined by Dr. Robert D. Truog. Dr. Robert Truog is the Francis Glessner Lee Professor of Medical Ethics, Anesthesia, and Pediatrics and Director for the Center of Bioethics at Harvard Medical School. His work has shaped some of the most important conversations in medicine around end-of-life care, organ donation, and the definition of death. Dr. Truog, thank you so much for being here. It's truly a pleasure.
My pleasure as well.
So to start, I'd love to ground the conversation in how we understand brain depth, both clinically and conceptually. So how do you define brain depth in a way that captures both its clinical meaning and what it's meant to signify when medicine declares that a patient has died, especially given that people often draw that line very differently on an intuitive, maybe spiritual, religious, or an emotional level?
Yeah, I think that there's been a lot of miscommunication about what brain death actually means. And so let me go back to one of the earliest thinkers about this, Christopher Pallas, who um, was a neurologist in Britain, and I thought wrote very clearly and concisely about the subject of brain death through a number of articles. Um, and he uh, framed brain death as a state of irreversible apneic unconsciousness. So irreversible in that we know that the person has a devastating brain injury, and we know that there's no confounding problems like maybe hypothermia or metabolic abnormalities that are causing it, that it's really structural. Um, Apneic, that the person will never be able to breathe on their own again. Now, they could breathe with a ventilator, but they can't breathe on their own. And unconsciousness, that they are completely insensate, do not feel pain, not aware of their environment, and cannot communicate. So that's what brain death means. It's a very severe form of a brain injury. And where I think we lost our way was in trying to communicate that this is the same thing as what we normally think of as being dead. Cold, blue, and stiff, or whatever, whatever other analogies you want to make. I mean, we're all very familiar in life with what it means to die. We've sadly seen many examples of that, whether you're watching TV or in your own families. And so I think the misstep was to try to equate these two things because they're very, very different.
Yeah. And I think that that kind of tension there between the media representations or what we kind of see colloquially as death and kind of this more kind of concrete concept of reversible apneic unconsciousness really gets at that tension there. And so to kind of follow up on that, the one of the enduring challenges here is that patients who meet the criteria for brain death can still exhibit integrated bodily functions like circulation, cardiac activity, hypothalamic activity, and in some cases, even the continuing of gestation in rare cases. So, how do we interpret that tension physiologically and conceptually? And I think you've touched on this a little bit, but yeah, I'm very curious.
Sure. Well, let's just, take a step back, is that the concept of living and dead is a pervasive part of the biological world. We're not just talking about human beings here. If you and I were to go outside for a walk right now and talk about life and death, we would completely agree, that this tree that we're looking at, obviously alive, this squashed bug on the sidewalk, obviously dead. we have deep intuitive understanding of what that means. And it was first described from a scientific point of view by Walter Cannon at Harvard Medical School back in the 1930s, when he coined the idea that to be alive was to be in a state of homeostasis. That is where our bodies use energy in order to maintain order within our body. And we're constantly fighting entropy, which is favoring disintegration of the body. And as long as those two things are in balance, we say that an organism is alive. That's a state of homeostasis. And when they're not, they're dead. Um, and this again applies across the whole biological spectrum. It applies to people, to our cats and our dogs, to insects, to plants, to bacteria. Um, Maybe when we get to prions or things like that, it might break down. But really, it's a biological understanding that far exceeds just what we talk about in terms of human life. And so the paradox here has been that the people that have been diagnosed as brain dead typically retain all of that homeostasis. I don't think it's an exaggeration to say that when we diagnose somebody as brain dead, they can do everything that you and I can do: absorb nutrition, excrete waste, heal wounds, grow, develop, uh, deliver babies. They can do everything that normal people can do, with the exception that they're never going to wake up again. They're never going to breathe on their own again. And this is where the tension has been, because I think there's been this fear that if we describe brain death accurately, that people will not really believe that it's dead. And so we sort of would lose the sort of foundation for organ procurement and transplantation, because there's just sort of this general view in the public that we shouldn't be removing organs from people until after they're dead. And it all depends, again, on how we're going to think about or define this concept of death.
Yeah. So building on that, your work has really pushed on this idea that brain death might not fully align with a purely biological definition of death, if that's a fair representation. And so
Very
if
fair.
Yeah. So if brain death is determined based on criteria, like you said, like irreversible apneic unconsciousness, but doesn't fully align with like a purely biological definition of death, um, uh, what function do you think this declaration is serving? You mentioned organ transplant earlier, so maybe you can expand on that, or if there's any other considerations here.
Sure. Uh, here's here's what it would look like, I think, if we talked about this openly and honestly. And I'll just speak for myself. If I'm ever at a place where I am completely unconscious, unable to interact with my environment, unable to live without support from machines and artificial nutrition and that sort of thing, my own view would be that, not to be glib about it, but I'm as good as dead. And it would be okay to treat me as being dead, certainly to the extent of not continuing to use things to continue my biological existence, but also if my organs could help others, that I would be willing to donate them. And in a sense, this is how brain death um, actually functions in our society, because when people meet the criteria, and we know that they're never going to wake up again, they're never going to breathe on their own again, we consider them to be legally dead, because under our law, that is one of the ways that we can make the diagnosis of being dead. So you're legally dead. And once you're legally dead, then removing your organs is not killing you. And so, I actually think that the most accurate way of talking about our definition of death under American law is that it's not biological death, but it is legal death. And it's something that, whether people have thought about that explicitly or not, I think people have been comfortable with over the past 40 years since we've adopted this legislation. Um, it's really only been in the last maybe decade or so that we've had some pushback to that of saying, okay, my child is never. I accept that they're never going to wake up again, never going to breathe on their own again, but I still want to keep them on a ventilator. I still want to have them present in my life, and so I don't want you taking out their organs. I don't want you removing their ventilator. I don't want you stopping their tube feedings. And this is where the controversy, I think, has been over the last several years.
Yeah, so that's a really helpful framing to understand what's happening here. And so, like you mentioned, when we think about brain death as more so this social construct or legal determination more so than a biological one, what do you think is gained and what might be obscured on the flip side by continuing to present it as a purely medical determination, even if it isn't intentionally done so?
Yeah, uh, I think the significance of this really goes beyond just organ procurement. I recently retired from the practice of critical care medicine for almost 40 years, and over that time, what I saw is that it is becoming increasingly difficult to die in an ICU if the clinicians don't let you die, right? And our ability to maintain biological existence is becoming pretty close to unlimited. ECMO was the biggest advance in recent years. It's a way of taking over heart and lung function. And because you take over heart and lung function, you're also supporting the kidneys, the liver, et cetera. And so, for patients who have the potential to recover, it's a fantastic technology, as we saw during COVID, where many, many patients, hundreds, maybe thousands of patients who would have died from COVID, by being supported on ECMO, were able to survive, come off ECMO, and do well. Um, and so I think we're seeing that the limits of that our technology is bringing us to a point where death is not quite, but approaching the point of being optional. And so then we have to say, well, then, when do we think that it's no longer a good idea to continue to support this biological life? And I think the point that we chose with brain death, again, never going to wake up, never going to breathe on your own, is not a bad place of saying, this is where we're going to draw the line. Now, whether we say you're alive at that point and we're going to let you die, or whether we're going to say you're already legally dead at that point, I think is somewhat arbitrary. It has saying you're already dead has some advantages. First of all, it removes the need to negotiate with families about it. I mean, it's a way of saying, no matter what you think as a family, this, your loved one sadly meets the criteria for death, and even if you want us to continue, we're not going to. So it serves as sort of a boundary for medical futility, for us to being able to say further treatment beyond this point is futile and we will not continue it. And then it also serves as a point where it becomes legally possible to remove organs for transplantation. And here for people who would object, I would want to point out that our organ transplantation system is an opt-in system. If you choose not to check that box on your driver's license and you communicate this information to your family, um, you can keep your organs. It's it. There are some countries in Europe, et cetera, which are opt out, which means that you're considered to be an organ donor until proven otherwise. No, we have an opt in system in the United States. So if you don't like all of these criteria that we've developed, brain death, et cetera, um, you have a way of expressing those wishes and having them be honored.
Yeah. So how should clinicians approach this tension in the clinic in making decisions about withdrawal of support for organ procurement? So I mean, you touched upon how like the brain debt determination kind of, helps resolve this to a certain degree. So maybe we can expand upon that more or if there are other important considerations here.
Well, let's take it into the clinical environment and talk about what it looks like in the ICU. I've made the diagnosis of brain death myself dozens of times, and um, there's always this challenge of where I'll speak about children because I do pediatrics, but a child with a devastating brain injury will be in the ICU on a ventilator, and they look just like a child who's asleep or sedated with a machine to breathe for them. And parents will look around the ICU, and there'll be other children who look like this, who we fully expect are going to recover and leave. And um, uh, parents very reasonably will ask, why do you think my child is dead? Why have you declared them actually to be dead? Why have you filled out a death certificate when, as far as I can tell, they don't look any different than many of the other children here? And sadly, I think that the way that medical professionals have responded to this, there have been some classic cases, is is to really kind of be demeaning to the parents. It's like, what do you mean? We've diagnosed death. If you don't understand it, well, then it's obvious that you just don't, you're not smart enough or something. Um, and I think that this has not gone well when that's been taken, and families have said, well, if you can't explain to me why we're dead, why my child is dead, then I'm going to get a lawyer, and they have successfully fought this determination of death. I think the honest way to describe it, and where I landed in the last several decades at least of working in an intensive care unit, was to say to families, um, we are 100% sure. We can come back to that 100% in a minute if you want, but I think I can say we are 100% sure that when we make this diagnosis, your child is never going to wake up, never going to breathe on their own again. And that's a diagnosis we call brain death. And in my state, Massachusetts, that is legal death. And so we have declared your child dead. I say this more compassionately than this, but for the sake of time, let me rush through it. And we have filled out a death certificate. And now there's really two pathways. One is we'll allow time for your families to come in and say goodbye and to spend time with your child. Or if you like, if you are willing, it would be a wonderful thing if your child's organs could be used to save the lives of other children. To me, that's a really honest way of describing it that respects the parents, uh, allows them choices, and I think avoids the the, tr- the true misconceptions that I think physicians often give to families about why their loved one is dead, which I think are not accurate.
So, I'd like to go back to like if you could talk a little bit more about like why you use 100% there, in that sort of communication. I'm curious.
Yeah. So one of the important tests we do when we're determining whether somebody is brain dead is whether they have functioning of their brain stem. And the brain stem is critical to our ability to be conscious. If the brain stem isn't functioning, in particular, there's this neural network in the brain stem called the reticular activating system. If it's not functioning, we know from the neurophysiology that has been done that you are absolutely unconscious. We can't actually test that neurological network directly, but we do know that there are nuclei in the brainstem that we can test, the things that like control whether your pupils respond when we put a flashlight into them and things like that. And so if we know that those brainstem nuclei are not functioning, we can be highly certain that the reticular activating system is not functioning and that you are unconscious. The reason I hedge a little bit on that 100% number is that there have been some patients, the most notable one being a young woman whose name was Jahai McMath, um, whose mother rejected the diagnosis of brain death and had her moved to New Jersey, which is the only state where you can legally refuse to accept the determination of death by neurological criteria. And she stayed there on a ventilator being tube fed for almost 5 years. Alan Schumann, who's a very prominent neurologist in this story, examined her multiple times over those 5 years, um, and thought that perhaps when he would persistently ask, Jahai, could you move your right thumb? Could you move your left foot? That there were occasionally times where she seemed to do that in response to the command. He firmly believed that she was responding to the command. There would have been testing that could have been done that could have confirmed or refuted this, but it would have required transferring Jahai to a facility that could have performed the sophisticated testing. And Jahai's mother said, no, we don't want to do that. She was cared for almost all that 5 years within, but the family had an apartment in New Jersey, and she was very rarely actually in the hospital during that time. But Jahai's mother would not allow that testing to occur, and so I want to give respect to Alan Schumann. He's a exceedingly good neurologist, but I think most people think it's doubtful that she did recover some function. We know that people that even after massive brain injuries like huge strokes and things like that, given enough time, will show some neurologic improvement. So that may have been what was happening, but I feel like that is so marginal of a case. And when I'm talking to parents in the ICU, I want to be able to communicate clearly to them. I think it would be disingenuous for me to say, there's a small chance that your child might survive. I mean, that introducing that small chance, I think, could make it very difficult for them to accept what I think is really the truth of the matter, which is that no, there's really not a chance that their child's ever going to wake up. And I think, for I think for many families, I can't tell you how many times families have said to me, "Well, my goodness, if my daughter's never going to wake up, why, of course there's no reason why we would want to continue the ventilator. I mean, why would we want to continue her in a completely vegetative state? And if she could help to save the lives of some other children, by all means, let's do that. I mean, that's the way that those conversations normally go.
Yeah, that makes complete sense. And yeah, it's important to kind of mitigate that suffering on all sides possible. So yeah, thanks for mentioning that. And we you mentioned a little bit earlier about the how the development of brain depth criteria is kind of historically intertwined with organ transplantation. So how do you think we should think about that relationship today? Not like necessarily historically, but more normatively.
Right. So let's step back a little bit from brain death here, and the kind of cardinal ethical rule of organ donation has been called the dead donor rule, which is that the donor must be dead before the organs are removed, and that the doctors must not kill the patient in the process of procuring those organs. And you can immediately see a problem here, because when people are dead in the normal way that we think about dead, when we think about the loved ones we know and we've seen them after they've died, this common sense understanding of death that we talked about at the very beginning of this, when people are dead in that way, their organs are just as dead as they are. You can't Their organs are not usable for transplant. So we've always fudged this, because in order for organs to be useful for transplant, the patients have to be dead enough that we can consider them to be legally dead, but alive enough that their organs can still be used. And so, as we've just talked about here, with brain death, they're still biologically alive. That's what makes them, organ donors. If they were not biologically alive, their organs would not be usable. So that's one. But then there's this other pathway that we use for organ procurement that's not the brain death pathway, which is where we wait until the heart has stopped. And we wait until the heart has stopped long enough that we are pretty confident it won't be able to start again. And then we procure the organs. And again, these are patients who are, again, in this liminal zone of between really dead and alive. Dead enough their heart hasn't been pumping for 5 minutes and it won't start alone again on its own, but alive enough that those organs are still usable. And in recent years, we have pushed on that technology more and more. And so now what we do, and there's this new technique called normothermic regional perfusion, or NRP, which really pushes this to the limit. So we start off, we say, okay, your heart hasn't been beating for 5 minutes, so we're going to call you dead. Okay, fair enough. We know it won't start again on its own. But then what we do is we put you on ECMO and we restore circulation to the body. And to make sure that you don't wake up, we put clamps on all of the major vessels that go to your brain. So we prevent any blood from going to the brain so you don't wake up. But we reanimate the whole body. The heart starts beating again. The kidneys start making urine. The liver starts making bile. And so it's a fantastic way of procuring organs in the best possible way. And it's been shown now that the organs that are procured via NRP are better than any other type of organ recovery comparable to that we see with the organs that we recover from brain dead patients. But we're fudging, and we know we're fudging. And so, my view, going back to where I said before, I think that we ought to permit patients to agree to have their organs procured from NRP. These are patients where a decision has been made to withdraw life support to allow them to die. They've shown that their hearts cannot continue to pump and will not be able to start on their own. They are not being harmed because they are already on a trajectory, an irrevocable trajectory towards death. They have given permission. They would like to donate their organs. There's people who need those organs. I feel like if you look at sort of all of the ethically relevant factors, they're all pointing in the same direction. We should find a way to make this happen. But I think we should be more honest about it and not do it under the ruse of saying, oh, they're absolutely dead, because they aren't. And so this kind of pushes us into an area where I think we need to be more transparent with the public. I think largely the public would endorse this approach, and I think people should be allowed to give a choice about that. So even if you check the box on the driver's license, my own view is that it ought to be explained transparently to the families and make sure that they're in agreement, that they're comfortable with organ procurement occurring in this way.
Yeah, I'm glad you mentioned transparency. So how do you think we can better facilitate this transparency and kind of better communication to patients, families, the general layman, and in terms of these concepts and helping them like form their own positionality here?
Yeah. Well, I think we are doing it. I think the protocols that are going to be used for NRP are currently undergoing revision. And I think, well, I don't know for sure. I think one of the outcomes could be that before we use this new really good technique, that we do obtain permission for using it. This has typically not been the case, is that if you've checked the box on the driver's license, it's really been up to the organ procurement organizations to decide how the organs are going to be procured, and families are neither really informed about the process nor given any choices. And so I think we're moving away from that, which I think is a good thing. I think general education of the public is a good thing. And I don't want to, I know that maybe the way I've been talking, I've been sort of expressing skepticism, and I don't want to feel that I'm expressing skepticism. I'm a little too old to be an organ donor at this point, but if I were younger, I would be, and only because my organs aren't any good anymore, not because I'm reluctant to. And so I think we want to remember that these people's willingness to give their organs saves thousands and thousands and thousands of lives every year. And so I think we want to be supportive of that generosity and encourage it. But I think we also, the worst thing to do would be, through the lack of transparency, to lose the trust of the public. Because once that trust is gone, it's very, very hard to get back. And I think the only way to maintain that trust is to educate the public and be open about what we're doing and explain why we're doing it and why we can do it in a way that completely assures the lack of pain and suffering from the dying person, which is always the most important thing, but also the viability of organs and really, in recent years, they're amazingly good quality in order to give years of life to the recipients.
Yeah, that's really helpful. And going back to your discussion of NRP a little bit earlier, I'm curious if you see kind of the like ongoing like ethical debates around it or kind of the legal debates around it. Are they just really mirroring what we've seen in the past with other life-sustaining technologies, or is NRP kind of bringing up brand new discussions to light?
Um, well, I think the pitfall with NRP has been don't ask any questions. We're telling you that your loved one is dead and just accept that. Now we know we've learned already that that's not been true for brain death. Um, we know that even after 5 minutes, if we tried to resuscitate these patients, many of them could be resuscitated. So we know we are in this sort of liminal state between life and death. And I think that we've really hurt ourselves by insisting otherwise and not being transparent. Um, I feel like I lost the train of your question a little bit there.
I
Can
mean,
you
yeah, I
restate
think
it?
you addressed it pretty well, but really, just are we just kind of seeing a repeat of the ethical discussions that we had around other life-saving or life-sustaining technologies historically? Are we just kind of seeing that being mirrored in current ongoing discussions around NRP, or is NRP? Do you feel NRP is completely new in that sense? Are we seeing some brand new ethical tensions or legal debates here when it comes to NRP?
Yeah, for me personally, this is I'm not sure this would be a view that would be widely shared. But for me, once we know that a patient is irreversibly dying, life support has been withdrawn, we have waited a few minutes to make sure that the heart is not going to start on its own. At that point, really the only thing that matters is that there's no doubt that the patient is insensate and feels no pain and has no suffering. And to me, the way to be absolutely sure about that would be to give the patient an anesthetic dose of an opioid. Um, Completely remove any uncertainty about that. The resistance comes from people who say, but if we are giving an anesthetic to somebody, it's kind of like hinting that maybe they're not really dead. And if they're not really dead, then we're opening this whole can of worms again. So I can understand the resistance to that. I can tell you that for many years I did anesthesia as well as intensive care medicine, and I was the anesthesiologist for a number of brain dead patients who came to the operating room to have their organs recovered for transplantation. And I always gave a big dose of fentanyl before incision began. Um, we know that when incision begins, patients their heart rate will often go up, their blood pressure will often go up. I don't necessarily think that that means they're experiencing pain, but why not just take it out of the equation entirely? Fentanyl is completely harmless in terms of the organs, and it removes any doubt about whether there might be some pain or suffering. Um, so that's sort of my view about it. I understand why people say, oh, but then we're completely giving up on the dead donor rule. We're saying we're not even sure that they're actually dead. And I understand the public relations issues there, but I think maybe over time we will be able to get past that and have what I think is a more rational approach to organ procurement.
That makes complete sense, and thank you for sharing that. And so as we begin to wrap up, I'd love to ask a more reflective question. And so looking forward, there's maybe a high probability that we might see new forms of life-sustaining technologies that we can't even imagine today. Do you think our current framework for defining death is sustainable, or are we moving towards a need for rethinking it?
I think that it is a mistake to redefine death. Death is a biological phenomenon. Again, going back to where we began, it's not just about human beings. I mean, it's, all the way down to amoeba and bacteria. I mean, the concept is biologically unifying. It's the loss of homeostasis. Talking about redefining death, I think, is going down the wrong path entirely. What we need to be talking about is, when is it reasonable to be sustaining life? What are the technologies that we can bring to sustaining life, especially when patients have the capacity to recover? And when we have passed that point, when the machines are no longer capable of sustaining a life that has meaning, for us, I think right now, the line that we draw is "you're never going to wake up again" is a pretty good line. When life no longer has meaning in that sense, then I think rather than saying people are dead, it should be allowing people to die in a way that guarantees that they have no pain, have no suffering, and if they want to donate their organs, they can do that too. But I think that line should be really separated from what it means to be dead or alive, which I think is where we got off on the wrong foot right from the beginning.
Right. And do you, or and kind of on a different avenue, do you think we need to be rethinking like the legal frameworks that kind of determine how we treat death in the clinic, maybe as opposed to changing a more biological definition of death?
Yeah, I'm going on to treacherous ground here, but there was recently an effort to revise the law on death, and it was abandoned. But one of the reasons it was abandoned was because of the views of a conservative litigator, James Bopp in Indiana, who drew the analogy, and and I want to be very careful here, drew the analogy between brain death and abortion. But I want to say why, because I think that the analogy is actually accurate. He pointed out that, and I think many of us would say that a very early stage fetus, no doubt, biologically alive, with the potential to become a sensate human being. But for those who are pro-abortion, it does not have the right to our continued support and existence, that it is ethical to terminate that life. And he was the one who drew the analogy to brain death. He said, look at brain dead patients, biologically alive. My view, they have the right to not have that support continued, or maybe even don't even have the right to have that support continued, and can donate their organs if possible. His view was the opposite. He said, look, they're just like an early fetus. They're biologically alive. They may not have much in the way of neurological function, but that doesn't make their lives any less precious. And therefore, we should be supporting brain dead patients in the same way that we should be supporting early stage fetuses. So he drew that direct analogy. And I say it with some caution, but I think it has some merit. He and I would come down on exactly opposite sides of it. But I think the symmetry is there, and I think provides some clarity to why people disagree about both of these highly contentious issues in our society.
Yeah. Dr. Truog, thank you so much for this thoughtful and illuminating conversation. It's been incredibly valuable to explore these questions with you. For those listening, we'll include additional resources in the episode description. And thank you for joining us on the Reapparition Journal podcast. We'll see you next time.
Great. Thank you so much.